All right, let's dive right in today. We're going deep on something that I think is so crucial in ophthalmology, and that's how sickle cell disease can really wreak havoc on the retina. We call this sickle cell retinopathy. And it's a pretty significant eye problem that stems from something that's, well, surprisingly common here in the U.S.
Yeah, you hit the nail on the head there. Sickle cell disease, it's not just one thing, it's a whole group of these inherited conditions. And the big thing to remember is that people with sickle cell disease, they don't have the typical hemoglobin A that we all have. Instead, they've got these what we call mutant hemoglobins, the most frequent culprits being hemoglobin S and hemoglobin C.
So if I'm getting this right, instead of the nice, round, flexible red blood cells we normally see cruising through those tiny retinal vessels, these folks have sickle-shaped cells that can cause blockages and all sorts of vascular mayhem.
Exactly. Those sickled cells are stiff and sticky. They can clump together, causing these log jams in the blood vessels. And this is particularly problematic in those delicate capillaries of the retina. It disrupts the blood flow, starves the retinal tissue of oxygen, and can lead to a whole cascade of problems.
And this predominantly affects the black population, right?
It does. In fact, it's estimated that around 10% of African Americans carry the sickle cell trait, and globally, it's a major public health concern.
Wow, those numbers are way higher than I realize. And we should also touch on thalassemia, right? Another genetic blood disorder that can impact the eyes.
Definitely. Thalassemia is less common than sickle cell disease, but still very important. It involves defects in the production of hemoglobin, leading to problems with red blood cell formation and function. And yes, it can also lead to retinopathy, although the mechanisms behind it are a bit different from those in sickle cell disease.
Okay, so it sounds like we've got a lot of ground to cover. Now let's zoom in specifically on the eye. When we're thinking about ocular involvement, which sickle cell hemoglobinopathies should be at the top of our list?
For the eyes, the big three are HBSS, HBSC, and SSAL. Let's break those down. HBSS is what we call homozygous sickle cell disease. This is when a person inherits two copies of the sickle cell gene, one from each parent.
So HBSS is the most severe form because both copies of the hemoglobin gene are affected, right?
Exactly. Then we have HBSC, where someone inherits one gene for hemoglobin S and one gene for hemoglobin C. And finally, we have S-cell, which is sickle cell thalassemia, a combo where they inherit one sickle cell gene and one gene for thalassemia. These are the folks who are most at risk for developing serious eye complications.
Makes sense. What about folks with just the sickle cell trait, HBAS, meaning they have one normal hemoglobin gene and one sickle cell gene? Or those with hemoglobin C trait, HbAc, do they
Yeah.
typically have to worry about retinopathy?
In most cases, sickle cell trait and hemoglobin C trait don't lead to significant retinopathy. But, and this is important, we can't let our guard down completely. There are cases where if someone with sickle cell trait also has other health issues, particularly things like diabetes or high blood pressure, they could be more susceptible to developing retinopathy.
Okay, so we always need to keep that bigger picture in mind. It's never just about one single diagnosis in isolation. Now, let's say we're seeing a patient and we suspect some form of sickle cell disease based on their history or exam findings. What tests do we order to get a definitive diagnosis?
Well, there are a couple of steps involved. We can start with what are called sickling and solubility tests, sometimes just referred to as a sickle cell prep. Think of these as the initial screening tools. They tell us if hemoglobin S is present in the blood.
So those tests are a quick way to flag the possibility, but they don't give us the whole picture.
Right. They can't distinguish if someone is heterozygous, meaning they have one copy of the gene, like in sickle cell trait, or homozygous, meaning they have two copies, like in HBSS, and they can't pick up other variants, like hemoglobin C.
So we need a more specific test to sort all that out.
We do. That's where hemoglobin electrophoresis comes in. It's the gold standard for diagnosis. It basically separates the different types of hemoglobin based on their electrical charge. Think of it like sorting different candies by color. It lets us clearly identify if someone has HBSS, HBSC, ISTAL, or other hemoglobin variants.
Perfect. So the prep tests raise the red flag, and then electrophoresis gives us that detailed breakdown. Now, the main goal of our deep dive today is to really get into the weeds of sickle cell retinopathy. We want to understand how it develops, the various ways it can show up in the eye, and how we approach managing it, especially with those newer systemic treatments you mentioned.
Right on. And that's what makes this such a fascinating but also challenging condition. You see, sickle cell retinopathy, it's not a one-size-fits-all kind of thing. It presents as this whole spectrum of changes in the eye. You might have some very subtle findings that only an experienced ophthalmologist would pick up on a detailed exam. Then on the other end, you can have really severe vision-threatening complications. So having a deep understanding of the whole spectrum is key for diagnosis and treatment.
Okay, so let's take it step by step. I'm looking at the outline, and it mentions a 5-stage classification system for sickle cell retinopathy. Could you walk us through that?
Absolutely. This classification system, it's based on the way the disease actually progresses in the retina, starting from those initial vascular insults all the way to the most severe complications.
And it all starts with stage 1, right?
It does. Stage 1 is what we call peripheral arteriolar occlusions. Think of it as the tiniest blood vessels, those little arterioles way out at the edge of the retina getting blocked off. Those sickled red blood cells, they get stuck in those narrow vessels and cause these mini traffic jams.
So we have these little roadblocks in the retinal blood supply. What happens next?
Well, as you can imagine, if the blood can't get through, the tissue beyond that blockage starts to get starved of oxygen. And that leads us straight to stage 2, peripheral non-perfusion. Basically, areas at the edge of the retina aren't getting enough blood flow.
So parts of the retina are essentially being cut off from their lifeline. Does the eye just give up at that point?
Not quite. The eye is actually pretty clever. It tries to compensate for this lack of blood flow by forming what we call peripheral arteriovenular anastomoses.
Say that 5 times fast. But seriously, what are those?
Think of them as these little detours or bypasses that the eye creates. It's like when there's a major traffic jam on the freeway and you take those back roads to get around it. These anastomoses are essentially pre-existing capillary channels that dilate and try to connect the areas with good blood flow to the areas that are struggling. It's the eye's way of trying to reroute the blood supply.
The eye's own little construction crew working around the clock.
Mm.
And that brings us to stage 3, which is where things start to get a bit more ominous, right?
Yeah, stage 3 is a bit of a turning point. This is when we start to see the development of peripheral C-fan neovascularization. These are new, abnormal blood vessels that sprout up in response to that chronic lack of oxygen in the retina.
C-fans. Why do they call them that?
Because when you look at them on an angiogram, which is a special type of imaging that shows us the retinal blood vessels, they actually look like those beautiful C-fan corals you see in the ocean.
I guess the eye has a bit of an artistic side, even when it's in trouble. But these new blood vessels, they're not exactly a good thing, are they?
Not really. They're fragile, leaky, and prone to bleeding. And they can even undergo something called autoinfarction, which basically means they clot off and turn white. We call those white C-fans.
White C-fans. It's almost poetic in a way, but definitely not a good sign.
No, not at all. It shows that there's been significant damage to the retinal vasculature, and it sets the stage for some potentially serious complications.
Like stage 4, which is...
Stage 4 is vitreous hemorrhage. Remember those fragile new blood vessels? Well, sometimes they burst, and when they do, they bleed into the vitreous cavity, which is that gel-like substance that fills the back part of the eye.
Bleeding inside the eye. That sounds really bad.
It can be. It can cause a sudden decrease in vision, or the patient might see new floaters in their field of vision.
And finally, we reach stage 5, the most severe stage of sickle cell retinopathy.
Stage 5 is tractional retinal detachment. This happens when those new blood vessels and the accompanying scar tissue that form in stage 3 start to contract. And as they contract, they can pull on the retina, causing it to detach from the back of the eye.
And a detached retina, that's a real medical emergency, isn't it?
It is. If it's not treated promptly, it can lead to permanent vision loss. So catching things early, ideally before it even gets to stage 3, is absolutely critical.
Got it. Prevention and early intervention are key. Now let's rewind a bit and focus on those earlier stages, what we call non-proliferative sickle cell retinopathy, or an NPSR. What's going on in the retina during this phase?
At its core, NPSR is all about the chronic blockage of those tiny arterioles and capillaries in the retina due to the sickled red blood cells. It's like a constant state of low-grade inflammation and damage to those blood vessels.
Look like a slow burn, a gradual process of wear and tear on the retinal vasculature.
Exactly. And we see a number of very specific and characteristic signs on exam. One of the most striking findings are these things called salmon patch hemorrhages.
Salmon patches, that sounds interesting.
They are. They're these intraretinal hemorrhages that happen after a small arteriole gets blocked.
Yeah.
At first, they're red, like any fresh bleed, but then, as the red blood cells break down, they take on this distinctive salmon color.
So we're basically seeing the hemoglobin breaking down right there in the retina.
In a way, yes. And then once those salmon patches resolve, they often leave behind what we call refractile spots.
Refractile spots. What are those exactly?
Imagine a little pile of glitter sprinkled beneath the surface of the retina. That's kind of what they look like. They represent deposits of hemosiderin, which is an iron-containing pigment left over from those broken-down red blood cells. They're a telltale sign of past bleeding.
Okay, so we have salmon patches, the active bleeding, and then refractile spots, the remnants of past battles. Then there are these black sunburst lesions that I see in the notes. Those sound pretty intense.
They can be quite dramatic looking.
Yeah.
These are areas in the peripheral retina where the retinal pigment epithelium, or RPE, which is the layer of cells behind the photoreceptors, goes through these changes. You get hypertrophy, hyperplasia, and pigment migration all jumbled together. We think they also arise from previous hemorrhages, maybe even those salmon patches transforming over time.
So even after those hemorrhages clear up, the retina is left with these lasting scars and alterations.
Yeah.
It's really a testament to the chronic nature of this disease.
Absolutely. And it's important to remember that NPSR isn't always confined to the peripheral retina. Sometimes it can affect central vision as well.
Really? How does that happen?
That usually occurs when the tiny capillaries and arterioles right around the fova, that's the very center of the macula responsible for our sharpest vision, become blocked. These occlusions can be really subtle and might only be picked up with special imaging, like OCTA, which gives us a super detailed view of those tiny vessels.
So even if a patient's central vision seems okay on a basic exam, we could be missing these micro-occlusions that are silently causing damage.
Exactly. And it's not just the tiny vessels. Patients with sickle cell disease can also have these spontaneous blockages in the central retinal artery itself or one of its branches. If we catch it early enough, treatments like high-flow oxygen and exchange transfusion can sometimes help restore blood flow.
It sounds intense. So we're talking about a real race against time to save the vision in those cases.
Absolutely.
Right.
And if those larger arteries are affected, it can leave behind some pretty characteristic signs like what we call silver wiring of the arterioles and also a sort of corkscrewing appearance of the peripheral retinal vessels.
Okay, silver wiring and corkscrewing. It's amazing how descriptive these terms are. You can almost picture exactly what's happening just by the name. What about the veins in the retina? Do they show any changes in NPSR?
Yeah, one common finding is venous tortuosity. It's basically where the retinal veins become more twisted and winding than they should be. We think it's related to those arteriovenular shunts we talked about earlier, those little bypasses the eye creates.
So all that rerouting of blood flow can really put a twist on things, literally. Now, that line also mentioned a macular depression sign. What is that exactly?
The macular depression sign is a bit subtle, but it's a sign that there's been some thinning or even a slight depression in the temporal part of the macula. It's thought to be another consequence of those pesky arteriolar occlusions, specifically in that area.
So almost like a subtle scar or a fingerprint of a past vascular event right in the central vision.
You could think of it that way. And then, of course, you can have these non-specific findings like peripheral whitening or darkening of the retina, which can just be general signs of ischemia or vascular damage in those areas.
And we can't forget angioid streaks, right? Those are pretty common in sickle cell disease.
You got it. Angioid streaks are these breaks in Birch's membrane, that layer underneath the RPE. They can happen in a surprisingly high percentage of people with HBSS and even HBAS, upwards of 6% in some studies. And they're thought to be linked to those chronic blockages in the choroidal circulation, which is the blood supply to the choroid, the layer beneath the retina.
So even though we're focusing on the retina, we can't ignore the choroid because it's all interconnected.
Exactly.
Right, sounds like NPSR is already a whole lot to deal with, and that's even before we get to the truly scary stuff, the proliferative stage. So let's talk about PSR, proliferative sickle cell retinopathy. What's the main driver behind this more aggressive form of the disease?
With PSR, the key problem is the growth of these abnormal new blood vessels and scar tissue that extend out from the retina into the vitreous. We call this extraretinal fibrovascular proliferation. It's the retina's desperate attempt to get more oxygen.
So the retina, sensing that it's being suffocated, tries to grow its own blood supply.
Exactly. It releases these growth factors, like VEGF, to stimulate the formation of new vessels. But unfortunately, these new vessels are kind of like rogue agents. They're leaky, fragile, and they can cause all sorts of trouble.
And I remember from the outline that PSR isn't equally common in all types of sickle cell disease.
Right. It's really important to understand the different risks. The highest chance of developing PSR is in folks with HBSE disease. It affects about a third of them. Then it's sickle cell thalassemia at about 14%.
And what about HBSS, the most severe form of sickle cell?
It's interesting, right? Even though they tend to have more systemic problems, people with HBSS actually have a lower incidence of PSR, only around 3%. And as we mentioned before, it's pretty rare in folks with a sickle cell trait.
So it seems counterintuitive that the less severe forms of the disease would be more likely to develop this serious eye complication.
It is, and we don't fully understand why that is, but it's something we definitely need to keep in mind when we're evaluating and managing these patients.
Okay, so we've got HBSC at the top of our worry list for PSR. Now, how does PSR differ from other causes of proliferative retinopathy, like proliferative diabetic retinopathy or PDR? Are there any telltale signs that point us towards sickle cell?
There are a couple of key differences. First, think about location. In PDR, those new blood vessels usually start growing in the posterior pole of the eye, closer to the optic nerve and macula. But with PSR, they tend to pop up more peripherally, out towards the edges of the retina.
So location is a big clue. Peripheral neovascularization makes us think sickle cell.
Absolutely. And the other big difference is that PSR is more likely to spontaneously regress, meaning those C-fan neovascularizations can sometimes just disappear on their own. That's much less common with PDR.
So seeing those white C fans, that's a pretty good indication that we're dealing with sickle cell retinopathy.
It can be a helpful clue, yes.
Now, are there any other signs of sickle cell disease that we might see in the eye, even before we get to the retina?
Oh, absolutely. The eyes can be a real window into what's happening systemically. You might see segmentation of blood flow in the conjunctival vessels, where the blood column looks kind of broken up. And then there's the classic comma sign, which is these little comma-shaped clots in the conjunctiva.
The comma sign. That's a pretty vivid image.
It is, and it's a good reminder that even those small conjunctival vessels can be affected by sickle cell disease. And sometimes you might even see what we call the nerve head sign of sickling, which is these little dark red spots on the optic nerve head.
So it's important to examine the whole eye, from front to back. Speaking of diagnosis, how do we actually determine if someone has sickle cell retinopathy?
Well, it all starts with a good history. We need to know if the patient has any personal or family history of sickle cell disease, or even just the trait. And then, of course, we do a very thorough eye exam, paying close attention to the retina. We look for those non-proliferative and proliferative changes we talked about, and we also specifically check for angioid streaks.
And imaging plays a big role too, right?
Huge role. Fluorescein angiography, or FA, is a mainstay. It lets us visualize the blood flow in the retina and choroid so we can see areas of non-perfusion, leakage from those new vessels, and those classic C-fan formations.
And OCT, I assume.
Definitely. OCT gives us these detailed cross-sectional images of the retina so we can spot things like retinal thinning, fluid buildup, or traction. And then there's OCTA, which is becoming increasingly important. It allows us to see the retinal and choroidal vessels without having to inject any dye.
So OCTA is a game changer for visualizing those tiny vessels early on, even before there might be any obvious structural damage.
It is. And wide field imaging is really important too, especially when we're looking for peripheral neovascularization. The standard photos might miss those areas out at the edges, so we really use a combination of all these tools to get a complete picture.
Okay, so we've got our clinical exam, and we've got this whole arsenal of imaging techniques. What about other conditions that might mimic sickle cell retinopathy? I know the outline had a pretty long differential diagnosis list.
Yeah, it's long because there are a lot of things that can affect the retinal vessels and cause similar findings. Diabetic retinopathy is probably the most common one we have to think about. And then there are various types of retinal vascular occlusions, both arterial and venous. We have to consider things like talc emboli from intravenous drug use, hypertensive retinopathy, and even inflammatory conditions like sarcoidosis. And some infectious diseases like dengue fever can also cause retinal problems. And that's not even the whole list.
Wow, that is a lot to consider.
Bruh.
So even if someone has a history of sickle cell disease, we still need to keep an open mind and rule out other possibilities.
Exactly. It's all about being thorough and considering the whole clinical picture.
Okay, let's move on to management. The outline starts with screening recommendations. What's the current thinking?
The goal with screening is to catch sickle cell retinopathy early, ideally before any vision loss occurs. The standard recommendation is for everyone with sickle cell disease, no matter what type, to have a complete eye exam every year. And that includes a dilated fundus exam.
So these annual exams are non-negotiable, even if someone has no symptoms and their vision seems perfectly fine?
Absolutely. Early detection is key. And as we talked about, those imaging tests like OCT and OCTA can be really helpful for picking up subtle changes that we might miss on a regular exam.
Now, what about managing the underlying sickle cell disease itself? Can that help protect the eyes?
Absolutely. That's one of the most exciting areas of research right now. We're realizing that treating the systemic disease can have a huge impact on eye health. There are these new therapies that stimulate the production of fetal hemoglobin, which doesn't sickle as easily as the adult type. And there's exchange transfusion, where we essentially swap out some of the patient's sickled blood for donor blood with normal hemoglobin. And a hyperbaric oxygen therapy is another area we're exploring. It can help increase oxygen levels in the tissues, including the retina.
It's fascinating that we can actually manipulate the composition of the blood itself to help protect the eyes.
It is. And then there's hydroxyurea, a medication that's been used for a while to treat sickle cell disease. We're finding that it also seems to have a protective effect on the retina. And the really cutting edge stuff is in gene editing. Techniques like CRISPR-Cas9 are being studied to try to permanently increase fetal hemoglobin levels. That could be a real game changer for sickle cell disease and all its complications, including retinopathy.
Gene editing. That sounds straight out of science fiction. But it's incredible to think that we might be able to actually fix the underlying genetic problem.
It's pretty amazing, isn't it?
Okay, the outline also specifically mentioned traumatic hyphema in Black patients. What are the special considerations there?
So, anytime a Black patient comes in with a hyphema, which is blood in the front of the eye after an injury, we have to think sickle cell. Even if they don't know they have the disease or the trait, we need to consider it because those sickled cells can really clog up the drainage system in the eye, and that can lead to a dangerous rise in pressure.
So the risk of complications from a hyphema is much higher in someone with sickle cell disease.
It is, and there's one really important thing to remember. We absolutely cannot use carbonic anhydrase inhibitors like acetazolamide in these patients.
Why not? Aren't those medications used to lower eye pressure?
They are. But in sickle cell patients, they can actually make the sickling worse. So if we need to lower the pressure, methazolamide is a safer alternative.
So it's a tricky situation where a medication that's usually helpful can actually be harmful in this specific context.
Exactly. We have to be really careful.
Okay, moving on to treating the retinopathy itself. What about anti-VEGF injections? Those are used for other retinal diseases, so do they work for sickle cell retinopathy too?
They can. Anti-VEGF medications can help shrink those abnormal blood vessels in PSR. But here's the catch. PSR has a higher chance of regressing on its own compared to other conditions. So we have to weigh the potential benefits of the injection against the risks and also consider whether it might just resolve without any intervention.
So it's a bit of a judgment call based on the individual case. What about laser? I know that's used for a lot of retinal vascular diseases.
Laser is a mainstay for PSR. The go-to treatment is called peripheral scatter photocoagulation. It involves applying laser burns to the ischemic areas of the peripheral retina.
And the goal is to.
The goal is to basically shut down those oxygen-deprived areas, which in turn can cause the abnormal vessels to regress and reduce the risk of bleeding. It's been shown to be more effective and safer than the older technique of targeting the feeder vessels directly. But we do have to be a bit more cautious with laser in sickle cell patients because they seem to be at a slightly higher risk of developing retinal tears after treatment.
So laser can be a double-edged sword, but in the right hands, it's still a valuable tool. And when is surgery necessary for sickle cell retinopathy?
Surgery is usually reserved for those really advanced cases, like a non-clearing vitreous hemorrhage that's blocking vision, or a tractional retinal detachment where the retina is being pulled off the back of the eye.
Yeah.
And sometimes we see combined detachments where there's both traction and a tear in the retina.
So these are the situations where the damage is already pretty severe.
Yes. And it's really important to make sure the patient is medically stable before we operate. We often consult with their hematologist to make sure everything is optimized. And during the surgery, we have to be very meticulous about maintaining good oxygen levels and hydration to prevent any sickle cell crises.
And I remember you mentioned that scleral buckling isn't usually the preferred surgical approach for sickle cell patients.
Right. Scleral buckling, which is a way of indenting the eye to help reattach the retina, carries a higher risk of causing ischemia in the front of the eye in sickle cell patients. So it's usually avoided.
Okay, so a lot of nuances and considerations when it comes to surgery in these patients. Before we wrap up, we should briefly touch on thalassemia retinopathy. How does that compare to what we've been talking about with sickle cell?
So, thalassemia is another genetic blood disorder where the hemoglobin production is messed up. The retinopathy is more common in the severe forms of the disease. And it can be caused by the disease itself, but also by the treatments they receive, like blood transfusions and iron chelation therapy. The main difference is that thalassemia retinopathy is usually non-proliferative, meaning those scary new blood vessels aren't as common, and severe vision loss is less frequent.
So while both sickle cell and thalassemia affect the blood and it can impact the eyes, the patterns of retinopathy and the overall severity tend to be different.
That's a good way to put it.
Well, this has been a deep dive indeed. We've covered so much ground, the genetics, the different stages of the disease, the imaging, the management, and it all really highlights the complexity and the potential severity of sickle cell retinopathy, but also the incredible progress we're making in understanding and treating it.
Couldn't agree more.
And I think the biggest takeaway is that sickle cell disease is not just a blood disorder. It's a multi-system disease that can have a profound impact on the eyes. So early detection, close monitoring, and a team approach to care are absolutely crucial.
Well said.
Now, here's a final thought for everyone listening. Given how interconnected sickle cell disease is, affecting so many different parts of the body, what do you think about closer collaboration between ophthalmologists and hematologists? Could working together more closely lead to better outcomes for these patients? Not just treating the retinopathy when it happens, but maybe even preventing it altogether. It's definitely something to ponder. Thanks for joining us on the Deep Dive.